Welcome to our session sponsored by the Student Division. We appreciate you coming. This is the Lost Survivors turned Suicidologists panel. I don't think there's a lot of discussion on people who are survivors that get into suicidology and the motivations and why, and that's what this is about. So we've got some questions, and I guess this just goes where it goes. First thing we're going to do, I'll introduce myself, and we'll go down the panel. Quentin's next to me, so I guess we'll just go that way. And we'll have the panelists tell you a little bit about who they are, what their background is. Again, my name is Chris Calkins. Lost my wife to suicide in 2003. I lost my brother to suicide in 2008. I've lost 10 colleagues of mine in the emergency medical services field. By trade, I'm a paramedic. So colleagues and friends, people I've worked with. I also teach, so some who are my students. So full-time, I am a program director for an emergency medical services program at a place called Century College in the Minneapolis-St. Paul area. I am a practicing paramedic still for a city called Woodbury, which is a suburb of that area. I do that part-time. I also have a nonprofit called the Stroop Calkins Center for Suicide Research, so feel free to look us up on the web at cheap commercial, suicideresearch.org, or on Facebook and like us. I do psychological autopsies, those kinds of things. A master's degree, I have one in public health, another one in interdisciplinary research. I'm a doctoral candidate. With any kind of luck, I'll finish up this December. My dissertation is Suicide Among College Students in the Role of Connectedness. And I'm at St. Cloud State University, St. Cloud, Minnesota. If anybody's familiar with that, probably hardly anybody knows where that is, but that's where I am. We're Huskies. Go Huskies. All right.
My name is Quentin Hunt. I lost my brother to suicide when I was 8. It was 1989. So I always, when I talk about suicide, I always say, like, I feel like my whole life has been about suicide, because it kind of has been. I mean, the brother, but like, you know, my hero, the guy I wanted to be like, pretty active in my church, Mormon. He baptized me. Like, it was a really big thing. So yeah, even though he was 20 years older than me, like, it was a big deal. I am a family therapist now, and I'm actually finishing a PhD in couple and family therapy as well, and I study suicide. Kind of started interviewing other suicide loss survivors about their experience. I'll do a cheap commercial for me Saturday. A colleague, Rebecca Sanford, and I are doing a presentation about that process of suicide bereavement, what helps and what hurts. Even though I'm still very passionate about the suicide bereavement, I've kind of evolved into working sexual and gender minority and ethnic and racial minority youth that are suicidal, because they're at higher risk than the general population. All right, I think my perspective of having lost a brother when I was a kid, and then from that moment on having thoughts of suicide myself, certainly something I bring into all my clinical work. I'm going to University of Minnesota, so even though we'd never met before, and the only time we've met is in Arizona, not in Minnesota, it's kind of a interesting thing. Go Gophers! Yeah, not that fun to say. Yeah.
Hi, I'm Abby Ridge Anderson. I'm a fourth-year doctoral student at Catholic University. I study with David Jobs, and I lost my best friend to suicide in 2004, 6 days after her 24th birthday. And we had been friends for almost exactly 10 years, like best friends since the day we met, first year of high school. And so I study, unrelated. I study adolescent suicidality, and I'm looking at adapting CAMs for suicide. And I'll get into this a bit more, but I had actually always intended to get a degree in psychology and study adolescent depression, and I never intended to study suicide. Even after I lost Charlene, I didn't intend to study suicide. And when I first started working with Dr. Jobs, I was like, it's just my master's degree. I don't want to do this for my life. But I thought about Charlene, and he does really good research. I'll do this for 2 years. Things have changed since then, but that's kind of how I came to this field, and just briefly, how Charlene has played a role in that loss.
My name is Danielle John. I am a clinical psychologist by training. I lost my grandfather to suicide in 2006 when I was in college. Up until that point, I was a religion major, because when you make 18-year-olds declare majors, they pick things like religion that are going to be very helpful later on in their life. But after I lost my grandfather and kind of learned about the problems of older adult suicide and really wanted to get involved in doing something about that, That's what led me to add a psychology major and eventually go on to graduate school and become a clinical psychologist. Now I am the head of behavioral health and research at a small private institute called Primary Care Institute in Gainesville, Florida. And the reason I chose primary care is because so many older adults do see primary care shortly before their deaths by suicide, and very few actually see, specialty mental health. So I felt like that was a really good opportunity. So I see patients there that span a broad age range. My oldest patient right now is 93, but my youngest patient is 16. And we also do some quality improvement type research, and I supervise graduate students and undergraduate students.
My name is Catherine Perouse. I am a licensed clinical professional counselor in northern Idaho, near the Canadian border. I got involved in suicidology because I lost my oldest son 20 years ago, day before yesterday, to suicide, and then 6 years later we lost our youngest son while he was serving in Iraq to suicide. And I just have this driving force to make it stop somehow. I know that sounds really simplistic, but I am a clinical supervisor. I manage the adult program in our small community agency. I am a fourth-year doctoral student. I hope I finish next year. God, I hope. It sounded like such a good idea when I started. And I specialize in suicidal behavior and treating people. I have a lot of adolescents on my caseload. And that's me.
And these are your family members in front of you, right?
Oh yeah,
Yep.
this is, can't see upside down. This is Daniel Robert and this is Bobby, while he was serving in the Army.
And I forgot to mention, that's Jeremy and my brother and my wife, Mary, over here.
My name is Regina Stifler. I'm a master's student at Grand Canyon University. I hope to be finished in June, although my graduation is tomorrow. The first suicide loss I had was as a paramedic. It was somebody I didn't even know, but he deeply affected me, and he looked exactly like my boyfriend at the time. And then in January, I lost my friend Laura, who I danced with for a really long time. And it's really, really raw.
I'll start out with questions that we've pre-prepared. We'll see how far we get down them, and then I would invite the audience, if you have any questions or things that are on your mind or would be helpful, to just blurt them out, stand up, raise your hand, do it, send a pass your picture. I think those are extinct. Up front, whatever. So I guess the first question is, what is the most rewarding thing you encounter in your pursuit of understanding suicide? So, I mean, what's the reward? What's the thing?
So I think for me is that, I know that there's a question about frustration. So that despite all of the frustration, which I'm sure many of us can discuss, and what feels like maybe it's really hard to make a difference piece of anybody's work when they're trying to create change and help people, when you are talking with somebody one-on-one who is struggling or suffering, knowing that you are working in a field and that you're, the time you spend writing syntax for your SPSS for like analyses and collecting data and reading and writing papers for class, all of that time, it's about at its foundation, it's about trying to help people who are suffering. And when you're with somebody one-on-one and you can sort of see, so like when I use CAMs with patients, my sister's actually been suicidal and I've not been her therapist, but I've sort of given her the example of the SSF to help her understand herself, which is our tool we use in our lab. And it helps. And helping one person is meaningful and rewarding, even in the context of great frustration and exhaustion and feeling like there's just too much for one person to do anything. Because helping one person really matters.
I think for me, I have a client that I worked with since she was in 7th grade, and it's been 8 years. And her goal in 7th grade was to graduate 7th grade a virgin. And she was suicidal numerous times. And she's now 21, enrolled in college. I mean, it's such a feeling of satisfaction to see her being successful, using the things that she learned. And knowing I can take a little bit piece of that as encouragement that I was able to make a difference. It makes me smile at night when I go to sleep.
Let me ask you a follow-up question to that. I don't know if you've lost patients to suicide.
I have lost one
How does
client.
that play?
Not well.
Is it like one person help and then they like you're two in the hole, like the game Sorry, you have to go back 2 steps or something, and then, or how does that work?
Kind of feels that way. Yeah, I really wrestled with when I lost my client. I don't really know. I just take them a day at a time. And on the days when I can look and I can see that it's made a difference and it's helped someone, I really take that for all it's worth and use that to keep going and try not to think about the 2 steps backwards. Because that's too discouraging.
I guess I like to think about it like traffic accidents, as paramedics and public safety people, we try to prevent traffic accidents, but you can't know when you do prevent them because they don't happen. So perhaps that's a source of comfort that probably helped you realize.
For me, the biggest reward in being in the field of crisis intervention is that I can stop people from becoming physically broken while they're emotionally broken. It's kind of proactive in a sense, proactive and reactive by helping those people before they get to the point where they're going to shoot themselves or take an overdose or whatever they're going to do. If I can intervene at that point, then maybe it'll save a paramedic from going down the trail that I went. So that's my reward.
Anybody else want to respond to that question?
Yeah, I think I can echo a lot of what's been said. Helping people, seeing people change, that's rewarding. But I'll be honest, like, there's another big part of it that I'm not that altruistic. Like, a lot of it is for me being able to be okay myself. I have to do something about it. Otherwise, it's the worst thing. And I struggle to want to wake up in the morning unless I'm working to do something to help other people. So yeah, I do a lot of altruistic things and really help people and connect with people. Yeah, I do, absolutely, but some of it's pretty selfish.
I was just talking about this kind of a concept like that at dinner last night, and I was telling the person that I think if I weren't involved in what I am, I mean, this like gives me my meaning, my purpose, I would be in big trouble myself, most assuredly. Is that a common theme that you feel?
Yeah, that's kind of what I'm saying. I mean, I'm not trying to sound like I'm just taking advantage of people to make myself feel better, because that's a thing that therapists do. No, but legitimately, like, it helps me to make the worst thing in my life a lot bit better. So yeah, I don't know what I would do, but helping, connecting with somebody when they're suicidal themselves, and we're able to connect about it, it changes them as a person. It changes me as a person. It's fantastic.
All right, the biggest barrier, the most frustrating thing about being involved in suicidology for any of you?
Crying in front of big groups.
How quickly the community can move on after a loss and just get back into their same old. I've worked long and hard in my community to increase suicide prevention and work with the schools, and it's all really important when we have a youth suicide, but within 6 months it fades away, and it does it every time. It makes me so angry. I'm not always as tactful as I should be. So that's probably the biggest frustration, is that unless it's right in your face, the majority of the community kind of just very as quickly as they can and wants to move on. And there is no moving on for us. I mean, well, there is, but you know what I mean? We can't just close it off and say, oh, well, that's really so sad, and then just go. At least I can't.
I think, as I mentioned, there are a lot of frustrating things, but I think for me, I'll just mention a couple. One is, it's not like a great way to start a conversation when someone's like, oh, what are you in school for? Oh, like, I study adolescent suicidality. They're sort of like, okay, like, I gotta go talk to somebody else. It's scary. It's really depressing. So I've sort of ended some conversations, not like I wanted to, but just sort of like people ask me questions like, what are you studying? And I tell them and they're like, okay. So I find that to be sort of like this part of what it means to be in the field is that people don't really understand it and it's scary, and so it can be a conversation stopper. It can also be a conversation like direction changer where you say you're studying adolescent suicidality and or just sort of you're studying suicide and they start talking about their own struggles or they start talking about their kid, and I don't have a problem with that, but it's also sort of then you're sort of what is my role and what are you looking for from me kind of experience that's just sort of a very low level like stress. I think that's true generally for mental health, but it's particularly tough when we're talking about suicide. And I had another one. There are so many. I think related to the sort of like what happens and people walk away, like I think sort of like people who aren't in the field and they have very strong opinions about suicide. And so when you hear people say things that indicate they think that person was so weak, how could they have done that? Or, you know, like basically sort of blaming the person who died and shaming the person who died and indicating that they were weak and or that like suicide is this thing that only these like people that are like broken and different from me do. And that's not like colleagues, but sort of like just people in my life, friends, whatever, that I find it very hard to not go off sometimes. Not with colleagues, with friends. I find that to be very, very frustrating, just the distinct dichotomy between like an understanding of being suicidal and that's, you know, some bad thing over there that only weak people do. Bridging that gap is hard and frustrating.
It happens with colleagues, too.
I mean, I feel very lucky. It hasn't happened too much with my colleagues, but yeah, I can see it.
I think my biggest frustration is about other people in the mental health field who don't have or see a need for training specific to this. Yeah. You know, there's been push in a couple of states to require CEs specific to suicide, and you know, Washington's passed it. I know Washington's passed it. I think Kentucky,
Oklahoma,
passed it.
Pennsylvania.
Not Idaho.
Yeah, well, so the California Psychological Association lobbied against a bill that would have done that because psychologists already know what they need to know about suicide when we know that that's not necessarily true. And so I think that's one of my biggest frustrations is that we have people kind of within our mental health world who don't see this as big of a concern as it should be. And then, you know, I work in a primary care office with a whole lot of medical assistants and nurses and primary care practitioners of various sorts, and just what they don't know about suicide is kind of scary. You know, I've had the opportunity to do some in-house stuff with them, but that's just my little practice. That's not the practice next door, the practice across town, let alone, you know, everywhere. So given that primary care is so much more ubiquitous than specialty mental health, that's also a frustration. How do we reach those people, not just people in mental health, but the people who could be helping us screen and get people into treatment?
Just to go back to the previous question I actually think that another really rewarding piece of this work is that opportunity to train people who need information, and that like you can't reach everybody in the world, but sort of like that dissemination of understanding, that opportunity to train other clinicians or providers is very, very satisfying. Although, yes, very frustrating that we have to do it.
It'd be more fulfilling if they showed up.
Right, yes.
I did 3 trainings a week and a half ago that 2 people showed up to. And while the exchange was really good and I really felt like I connected with the parents, it was a little frustrating that in an entire middle school, 2 parents showed up.
Yeah.
And it was to discuss not just suicide prevention, but how the 13 Reasons Netflix wonder thing is impacting their children. 2 parents.
Can you, maybe there's people out here who don't know what 13 Reasons is, could you give a very brief
It's a Netflix show about Hannah, a girl who ultimately kills herself, but she leaves 13 messages to people that she says contributed to her killing herself. There's a lot of problems with the show. I encourage all the parents to watch it with the kids. There's also a half-hour trailer afterwards. And most parents don't even know it's there, and I encourage it with psychologists and psychiatrists and people in the mental health field that talk about all the things that are missing and the assumptions that are just there. And there's a lot of good information on the internet. If you look up 13 Reasons, there's talking tips. Talk to your kids for parents. It's a disturbing, I have not watched it. I can't bring myself to. Figured I didn't want to ruin my week. But I've read everything that's out there on it. And it's just a little frustrating that parents are so disengaged from their children that only 2 parents showed up to come and talk about it.
And I just finished the series, so I can tell you what's in it, because I thought, I gotta watch it, otherwise I can't, So, they do everything you're not supposed to do. They put this gal up on the pedestal, and, the friend of the kid said, when the other kid might be suicidal, you're not thinking of doing anything stupid, are you? And then they show the suicide. Every once in a while there's like the kid hallucinates that the dead girl's in the middle of the gym, and she looks, all pristine in a white dress, and, all this stuff, and it's scary stuff to watch, and never really mention that she struggled with mental illness at any point. And then the one high school counselor she went to rebuffed her. Of course, that's not the usual experience. So these are all things that I think are very concerning. I teach at a community college, and we also have a intermediate high school district with us, and that's all the talk amongst the high school kids right now. So I'm not really worried about that.
I don't know, I watched the show, and it touched me, and I cried, and I loved it. Yeah, they did a lot of things that they're not supposed to do. And they did a lot of things that AAS and the American Foundation of Suicide Prevention, the JED Foundation, told them not to do. But I think it really showed what it was like to be that kid. And I'm not sure you can get diagnosed with anything after you're being depressed and suicidal after being raped. I think that's a pretty normal reaction. So I recognize my stance is very unusual here. But that show, there's a lot of problematic stuff, but I agree. But I think it can be used as a great tool to talk about the messed up shit that's going on in people's lives when they are suicidal. It's not just all these things, but feeling like a burden. You lost your parents' money. How are they going to cut out your house? You're going to lose your business. That's burdensomeness. That is one of the mechanisms of adolescent suicidality. That's one of the things we should be talking about. But instead, I'm kind of frustrated that we're just talking about the safe language things, which are important. It is important. But I think there's so much deeper conversation that could be happening, because it's about emotion, and it's about not feeling loved and feeling like it could never get better. And I think those are some of the conversations that we could be having about it. And it is hard, and it is hard to watch. I can't fault anybody for not watching it, because it is tough. It is really tough. But I also think it's kind of like what it was like to be that 16-year-old kid.
Any further comments? So what was the greatest, switching gears, what has been the greatest help to you in engaging in the field of suicidology? What helps?
I have the best coworkers in the world. They're all super supportive when we're going out and doing like difficult cases, especially with kids. They're all there for me when I come back and I'm upset.
Mine has been Span, Idaho, and our wonderful executive director who's back there in the 4th row. I don't know what I would have done without Jenny. I call her, I text her, say, okay, I need to talk. And it's somebody to vent through, and she keeps encouraging me. And yeah, you gotta have somebody like that encourages you and listens to you and supports you and says, you can get it. So that was invaluable to me, because I had a lot of not so great support from people.
I mean, in terms of actually like getting into the field and stuff, it would be AAS. Like I came to this conference the first year as a survivor, just for the loss conference. But I was at UF at the time, and they gave me some money, and it was in New Orleans, so I was like, well, I'll go for 4 days instead of 1 day, why not? And I discovered that this kind of was a field at that point, and that people were really nice and supportive, and I learned about the Healing After Suicide conference through a support group I was going to. And somebody in that support group had also given me Thomas Joyner's book and said, this might be helpful for you to read to try to understand what just happened. And I read it, and I did kind of connect with some of the things in terms of my grandfather's death. And then Thomas Joyner was like at the conference, and he like talked to me one-on-one, and it was, you know, mind-blowing. And that was really when I kind of decided to like get into the field. So I think my experiences in that way, and being able to come to this conference every year pretty much since then, has been really important for my career.
Yeah, I was gonna, can you phrase or restate that question? Like, is it who or just generally what?
What? Well, you could say what or who has been the greatest help to you in engaging in the field of suicidology.
So yeah, I think, and this is gonna sound like I'm like an advertisement for this year's conference. It's absolutely mentorship. Like you see somebody who's doing the work and they're passionate and they're doing a good job and they're open to you joining us, like joining the field. Like that, it's not like some person over there, like you're so fancy. And I mean, you know, we all have that like starstruck, like there's Joyner or whatever, but because the field is like or AAS is this relatively small or close-knit or like family-like conference and organization, I think that like that allows people to get into the field, to feel okay, like saying like I could do this, and then just having a mentor who connects me with people. But in terms of the what, I would go back to like what's most rewarding is like being passionate. Like I think really being passionate about what you do is like enables you to stay engaged and to keep pushing forward, and just passion really matters. The caring about what we do.
I agree that everybody here is pretty accessible. I also got to talk to Thomas Joyner one-on-one, which was interesting. And I tell you what, he writes the nicest rejection letters ever for the suicide and life. No, I'm serious. He really got it. It's like, wow, I feel good about being rejected. He does it very nicely. I'll have to frame that. Has anyone ever discouraged anybody on the panel here from studying suicide? Have you ever been discouraged?
My parents.
My parents.
My mother and my father never understood why I would do this. I don't know, your grandsons, hello? But they never, ever understood it, and they were very vocal about it. So then they just decided to focus on the fact that I had a master's and was going for a PhD. My daughter's getting her PhD. That's all we're going to say.
I similarly, when I was just like dipping my toes in, like I'll just do this for a couple of years, my master's program, it was after that, my mom was like, all right, well clearly she's just doing this, she's not stopping. But during those 2 years, she just kept telling me over and over, Abby, you're too sensitive, you can't do this work, you're too sensitive, it's going to be too hard for you, I don't want you to burn out. And I was like, you're right, like I'm not going to do this work, it's just for 2 years, I can't do this for my life. But I think I can. It's been like 6+ now, I think I'm okay.
I got kicked off of volunteering for a crisis line.
Oh,
I was
really?
rejected from volunteering for a crisis line.
Yeah.
Tell us the story.
Yeah, so it was probably like 6-ish months after my grandfather had died, and I wanted to do the psychology thing, and so I was looking for research opportunities, volunteer opportunities, because I was like kind of late to the game. And I went and volunteered for the crisis line, and I didn't mention my grandfather when I started because I just didn't feel particularly relevant. I just wanted to help. And then we were going through the training, and the director pulled me aside after I disclosed it at some point and said, I don't think you're ready for this. And I said, I think I am, I'm fine. And she said, well, no, like you're not going to continue in training. And it was a very unilateral decision. So,
Wow.
yeah.
So I guess a related question would be, has anybody ever told anybody they were, and this is sort of your situation, but too close to the topic of suicide as a survivor to actually study it or research it or anything else? Because I've had that comment like, you know, you've been affected by it so much, wasn't that going to bias the study? And I kind of say, well, it's like saying a cancer survivor can't study cancer. I mean, I don't know if anybody had that experience.
Yeah. So, I mean, I think it's a big deal. Most of the work I do is qualitative, and I interview people about their experiences, and that's a legitimate concern. I also think that it makes the work that I do richer because I understand more about that. But that's why you get another people that have different experiences. That's the thing. Yeah, I was fired by three graduate school advisors because they said they had no interest in depression or anything related to suicide. Another one said she wouldn't work with me because it was too close to the topic, and there's no family therapy program. I don't see how family fits into suicide. I mean, just long rejection after rejection after rejection before finally someone was willing to take a chance on me. So yeah, that's it. Sorry, I combined two questions there. That was my experience.
You're making me think of the ABBA song now.
I totally lived, started playing.
You know, that actually, when I think of this advisor, like, yeah, it going through my head every time. It's like, really?
I think for me it's not come up so much research-wise, but clinically, especially when I was still in graduate school, I had a couple supervisors who were really uncomfortable with me seeing anybody who was suicidal because...
So you have done your own work now, haven't you?
Yeah.
Now
So,
this year's a suicidal client. Do you need to go do some more of your own work?
yeah. So I think...
Trust me, I know when I need to do my work.
And I think that there's been times, like even just recently, where I did have reactions that I really didn't expect. It's been over 10 years now, and had to kind of check in with myself. So sometimes it's not about somebody else deciding it for you, but you sort of realizing that it comes up unexpectedly.
Well, and then paying attention to when it does.
Yep.
When we had the conference in Austin, because there was a suicide offer there, and it was a jumper, which is what my oldest son did. And I thought I was okay. And I was home about 2 days, and I just could not stop thinking about it. And it was me paying attention to, okay, you need to go in for a tune-up. And I did, and it was fine. But initially, I thought it was way cool. There was no problem. I mean, it wasn't cool, but I was okay. And it just kind of turned out, no, it really wasn't as okay as I thought it was. But you pay attention to yourself so that you know when you're not okay, and you address it. Yeah, that's so far anything I've got interviewed for, it's like the third question.
And I think maybe as survivors, we do have to check in with ourselves a bit more and kind of focus more on that self-care aspect than perhaps people who haven't had that experience. But like Quentin said, sometimes it makes the work more rich and meaningful.
So the next question is, do you always disclose, or do you disclose that you're the survivor of suicide loss, unlike me who's on the research end of it? Everybody else here is also on the, sounds like the clinical side of it. So I guess you could answer that question with both hats on. Would you disclose that during your research or to a client?
I have with clients if it's clinically indicated. It's not very often, but there have been times when it enhances therapeutic relationship that I do understand, and it is possible to understand what you're going through. Research, I really haven't because I don't see that it's pertinent. And a long time ago, I quit bringing up the topic because all you got to do is say, oh yeah, I got 7 kids, but 2 of them are dead. Oh, how did they die? Suicide. The whole room clears. So I learned a long time ago that's not a topic to bring up, unless I want to be alone. Then it's really effective.
So I think that I don't disclose that I'm a survivor. But then as like you asked the question, I realized I don't know like when I wouldn't, like when I've deliberately not. So when my very first like interview with Dr. Jobs as a master's student where I wasn't going into the field, I was like, I'm interested in your lab, not because I really want to be in this field, but because I lost my best friend to suicide and I thought this would like be interesting. And that like I had no idea that there would be any stigma because I was like brand new to like research, and it just didn't occur to me not to. And nonetheless, as like I've been in this field, I have this sense that I've not disclosed. But then I think more it's like sort of, I don't know when it's that relevant to say. that this is a part of my experience. Because I wouldn't, like if somebody asks me, I would talk about it. I'm not going to introduce it. Clinically, I don't know that I would disclose that to a client, but I don't disclose it to my supervisors. Again, not because I'm holding back, but because they've never asked me. I mean, I'd say it if they asked. But I think it's more like this sense that I shouldn't than like any reality that I don't. If that makes any sense.
I find when I do psychological autopsies, it often opens up the door for me, and I can get in places where other psychological autopsy investigators cannot. Because if the person knows I'm a survivor too, the door will, that's where it comes in for me, like the door will open. Otherwise the door tends to get slammed in other people's face like a portion of the time.
I would say research I always disclose. I mean, a lot of it is the nature of the interview process that I'm doing. But I guess pretty soon I'm not going to be able to say this anymore, but also because every single person I've interviewed said they wouldn't have done it unless I had disclosed. Like, they were willing to talk to me because I said that I was a suicide loss survivor. I say eventually because I'm going to interview somebody that's a little more open, and eventually, as I've been interviewing more and more and more people, as I keep going. But as a clinician, frequently, if it's important. I don't always, but sometimes I do. If there's someone that's going through suicide grief, absolutely. Because again, it's about not being an outsider. Like, insider, I get it. We're in this together. Like, but if it's an adolescent kid that's struggling with thoughts of suicide, or an adult, it depends.
It depends on if it ends up being relevant.
Yeah, it depends.
And sometimes it is.
Sometimes it is. Yeah.
I've disclosed it as a paramedic a few times. Example would be a 16-year-old girl. She's at a psychologist's office. We get called there for some unknown behavioral health issue, and I asked the psychologist what's going on. She's just having a bad day. So we get her out to the ambulance, and I start talking to her, and I just had this spidey sense, I guess, that it had something to do with suicide. I don't know why, but I just felt like it had something to do with it. And it turns out it was the 1-year anniversary of her dad's suicide. And that's what the depression was about. So we had a very open and honest, I said, I've lost family members too. That sucks, is basically what I said. And then she opened up and started talking to me. But everybody else was, and I was stymied, because even the mental health profession is just having a bad day. I mean, yeah, that's a hell of a bad day. I don't know if, Regina, you've ever been a paramedic as well. I don't know if you've ever experienced anything like that. This is a different environment, of course.
I mean, I certainly would disclose as a paramedic. I don't as a mental health practitioner, except to like my coworkers and my supervisors. I don't tell my clients because it's not about me, it's about them. So yeah, I can see it being helpful in EMS when people actually do EMS the way it should be done.
That sounds rather.
I get the EMS in our city does not do anything with mental health. They're just like, it's not our problem. It's not a medical problem. So we can't take them.
Last time I checked, our 911 call volume was, of all the 911 medical emergencies, was 7% was behavioral health related. Quite a hefty number. We actually had to struggle even to get police. There's the legislation is changing in our state where police officers now have to get trained in mental health, because it hasn't kicked in yet, and this is Minnesota, but they finally now are going to be required to get education on mental health when they graduate from their degree program, which they weren't required to before.
I think Idaho requires 4 for post.
Right.
Although CIT has, there's crisis intervention training, 40-hour training has really expanded in Idaho. And we probably have, I don't remember what the last numbers were for the number of law enforcement people, but a lot of them in a lot of small rural communities like Sandpoint and Bonners Ferry and St. Mary's, really tiny places. So it's taken a long time. This has been I guess 9 years since we had our first CIT training. And it's gotten a long ways towards changing and making it so that law enforcement is more able to address mental health needs in a constructive way. Or they don't always do it, but they have been trained.
Well, I think any profession, whether it's paramedics, nurses, doctors, psychiatrists, social workers, whatever, there's good ones and there's bad ones. There's good electricians and there's bad electricians, you know. I mean, so I don't think that's unique. How about what advice would you give a new survivor of loss who wants to enter the field? If you could go back in the time machine to you, that'd kind of freak you out if you showed up, but what would you say to you?
Make sure you have somebody you can talk to right from the very start about what you're working on, and somebody you can confide in.
I don't know, I just kind of fell into suicide prevention, so, and it wasn't until after, let's see, it's like a year after Bobby's death, so I was 7 years into it for the oldest son, and I just kind of fell into a SPAN meeting, and I was just it felt so much like somebody had thrown me a life raft. I was like, oh my God, there are other people out there that care. I can't believe this. Because it really felt like I was the only person. I didn't know anybody else. And it's certainly not something you talk about with, at a PTA meeting or anything. So, at least then I did. That was probably get connected with a group, because it'll really help guide you, feed you, and educate you. And that was, I don't know what I would have done without SPAN. Probably some blithering idiot in the corner or something in North Idaho. Crazy North Idaho lady.
If anybody, a cheap commercial, so if anybody wants to talk about the Intermountain West, come to my presentation tomorrow on the culture of the Intermountain West.
Oh, yeah.
Which Idaho is a part of that.
Oh yeah, I live 13 miles from Ruby Ridge, okay?
So for me, like similar to you, like I was 5 years after my loss before I even considered studying suicide briefly. But I think that if I could go back to like that first, say like year to year and a half, where the like sort of emotions were so raw and intense, I would say I would try to like give a picture of what I would call post-traumatic growth. Because last fall I was at the AFSP Out of the Darkness walk, not the overnight, and my whole lab was there, and it was this whole community of people like here where people care and they're showing up. And I just felt very connected with a really important, strong community, like I do every year when I'm at AAS. And I remember just sort of taking this moment and thinking like, wow, like losing Charlene has shaped my life completely. And that's come with a lot of negatives, but it's also given me a career. Like literally my entire career has come from this loss, and I love what I do. And I feel very, very lucky to have a career that I'm very passionate about and that I think I'm good at. And it's all come from that loss. And so if I could give my grieving self this idea that like something good can come out of this and there will be this hope and growth. This isn't like career entry advice, like how to get into the field, but more sort of like what being in the field has kind of done for me, and like that it's because of her, specifically because of her death.
For me, I think it would just be kind of a reminder to myself that grief and self-care aren't time limited, shouldn't be. I started grad school about a year and a half after my grandfather died, and that fall semester went, fine, and I came within inches of failing out of grad school that spring because I was so sure I could just do it and handle it and talk about suicide all the time and, meet with suicidal older adults and not be bothered because it had been 2 years, like I should be fine. And it took a very adamant but caring advisor to kind of get me to where I needed to be and back on track. I actually ended up taking a semester of leave to work through stuff before I got back into it. So I think, really, if I could go back and remind myself of that, that would have been good.
I would have told myself to come to AAS. I mean, I stumbled on it because I had a friend from high school who was actually working in the Arizona Department of Suicide Prevention here, and she was recommended to me. But it's interesting, like 28 years ago today was when we found my brother's body. Like, it's this time of year is always a tough time for me. And it's been one of the best things that I've for me, because it's a time that's tough for me when we come and we talk about suicide prevention and connect with other people that have also experienced loss. And it's been really good for me. And good for me professionally as well.
So what advice would you give a non-survivor of loss who's entering the field?
Some of this I say tongue in cheek, but also absolutely seriously. We're kind of sensitive folk. And that's one thing that I would say is this is a really raw thing for us, even 30 years later. I don't think it makes us crazy. It doesn't make us broken. Doesn't make us mentally ill. But things have deep meaning for us. And I think one of the greatest struggles that is in being suicide bereaved is making meaning. And so we have a lot of things that have meaning. So a lot of statements that have meaning. And we're sometimes prickly because there's a lot of trigger statements that have really deep meaning and are offensive. And I think most people don't mean to be. I legitimately think so. I just think they're ignorant and refuse to see that they just don't know. And I think just being willing to admit that you don't know. You're going to say things that are offensive. It's not anything wrong with you, it's just you didn't know. And take it that way rather than saying that I'm overly sensitive. That's what I would say. Just have a little compassion.
Don't say commit.
Don't say commit. Absolutely. Every presentation I say,
do it.
Don't say commit.
It's like
no
shooting
more.
up a flare, isn't it?
It is.
You got our
Absolutely.
attention.
No, seriously. If someone says commit, I absolutely know you're not one of us. That's how I know.
Yep.
You're not one of us. I can't say what's really going on for me.
And don't try to find the bright spot. Don't say, well,
Yeah.
at least it wasn't your biological child.
Yeah.
Okay, you want to watch me rip somebody's face off?
Yeah.
I think that you had said something earlier, Quentin, that I would actually argue a little bit with when you were talking about, like, that sort of one reason for disclosing that you're a loss survivor to sort of help a client understand that you know that they've been there.
Yeah.
Which I don't fault you for that in any way, but more this idea that, like, one couldn't be there with somebody emotionally. Like, I believe that, and we were sort of talking about this earlier today at lunch, I do feel like, it's one of the reasons I love AAS, that my experience is that there are some people who study suicide as like this over there thing, like these like, how on earth could somebody be suicidal? I don't understand it. I'm so curious. I'm going to study those people. And then there are people, like pretty much everyone that I've met at AAS who are studying suicide, who are more like, here I am and here you are. Let's understand your experience together. Yes, I'm trained by Dave Jobs and I'm talking about camps. But I also feel like that's very much like, not just clinically let's do that, but as researchers, as people who study suicide, I think that there's a feeling for some people of specimen. Suicide is this like thing that we have to understand because it's bad and these bad people do it. And then there are researchers, whether or not they're loss survivors or people with lived experience, who can really put themselves in that place of empathy and sort of say, I'm approaching this research from a place of like connection and wanting to connect and understand because I care. And I'm not saying the other kind of people don't care. I just think that there's a way of being empathic, and I think that that's, as a non-loss survivor, be that empathic kind of researcher and worker.
I think self-care is important for non-loss survivors too.
Yeah.
That's, I think, a huge thing. And then I would say there's no such thing as a typical loss survivor. Everybody has their own experiences and differences. And like Catherine was saying, sometimes when I tell people I lost my grandfather to suicide, somebody will say, well, at least it wasn't like your child. You know, that was still a very hard loss for me. And so my experience losing my grandfather is probably not the same as somebody else's experience losing theirs, and it's certainly not the same as somebody else's who lost a friend or a child or a sibling or whatever. And 10 years down the road, I'm not in the place I was a year out. You know, like it's all just like any grief. And sometimes I feel like when we talk about survivors of suicide loss, we lump everybody into this group, and it's sometimes I think we're more different than we are similar.
It's interesting. I'm remarried, so I don't always disclose readily that. I'm sorry, my wife's here, so sorry, but I don't always readily disclose that I'm married. And the reason I don't do that is because then it's almost like instant judgment. Because then the follow-up comment a lot is, oh well, at least you moved on. Like it was, you know. So I always give the analogy. It's like losing a child. I mean, it's like saying, well, at least you have another child. I mean, that would be. I mean, you can apparently the human heart has the capacity to love two people equally as much, but in a different way, and you can't choose. And in fact, your brain feels like it's, sometimes you think these weird thoughts like, oh, what if I could have that person back? What would I do? And then your brain feels like it rips in half, and one half runs that way, and one half runs that way. But you know that that's never a possibility anyway. So then you're relieved. You never have to make that choice, because I don't think I could make that choice.
Yeah, that I'd give anything to have her back, and then you sort of think through the logistics of what would you give up? Would I give up my husband? I can't make that choice. I can't.
Right.
I will never have to. Okay. Yeah, I think that. I'm guessing many of us have had that sort of.
Quandary.
You described that beautifully.
Great. Well, we've only got a few minutes left. Are there any questions from the audience? Has been pretty quiet. Any questions that anybody has of us?
Well,
Yes.
I just wanted to thank all of you for doing this. I'm also a loss survivor, and not clinical, not research. I do training in suicide prevention in the state of Tennessee. Lucky enough to do that with my background in public health, and it's a different aspect than literally a year after my father died. I was in grad school, not a smart idea, but it happens sometimes, and I just want to thank you all.
Thank you. You're welcome.
One thing I jotted down when you said about tears, I think tears are okay.
Unless they're not.
Unless there's a lot of them and there's a power source nearby.
That's
Yeah.
And that's a problem.
Well, the first counselor, or second counselor I went to see after Daniel, my oldest son, died, I remember sitting in her office going, oh my God, she's crying harder than I am. This can't be helpful. I think I'll leave now. So there can't be too many.
what she did today wasn't
Yeah.
I appreciate that.
hard
It was
enough.
good. Question from the back row.
I'm just seconding the payment of thanking you, and I liked the comment on how different survivors are. I'm a survivor. I've been a researcher for almost 30 years, but in other sort of workforce kind of things, and I only fell into research and suicide in the last few years. For me personally, I don't think I could have dealt with it anywhere in the first 10 or even 15 years. But that's not to judge anyone who got involved in suicidology after just a year or two, because we're all different. I did a paper maybe 6 years ago where there was all this talk about how millennials were different. And I went and looked at some of the different survey results and everything, and the millennials answered a question slightly skewed a different way than, so there was this huge distribution of difference among millennials and this huge distribution of difference among everyone else, and they just took this little difference in an average and said, oh, millennials are this and everyone else is that. And I think it's parallel. I mean, survivors are all over the map. We're all different, and non-survivors are all over the map, and we're all different. And we just differ from each other in this one dimension.
Well, it's been an honor to be here with all of you. Thank you.
Thank you so
Thanks,
much
Chris.
for hosting us, Chris.
Thank you.
So that's all we've got.
Thank you for coming.
Thank you.